Thanks to the organizers for inviting us to give this oral poster. It's number 23. I hope to see all of you at lunchtime for more details. This is just 5 minutes. And a small correction, I haven't yet migrated to the UK in the program. I'm from Uganda. So I'm presenting this on behalf of many co-authors, some of whom are in this room. And this is HIV drug resistance work within the CHAPAS-4 randomized trial. The background to this is that CHAPAS-4 trial already demonstrated superior virologic efficacy at 96 weeks for dolutegravir versus boosted lopinavir, atazanavir, and darunavir, and also superiority of TAF plus FTC versus the abacavir or zidovudine combined with 3TC. And this was in an African children starting second-line ART following treatment failure on first-line NNRTI-based regimens. So we randomized 919 children to anchor drug and simultaneously to NRTI backbone. The anchor drug, as already explained, was DTG versus boosted darunavir, atazanavir, and lopinavir. And the NRTI backbone was TAF plus FTC versus the standard of care, which was abacavir or zidovudine, depending on which was not in the first line, plus 3TC. We did viral loads at baseline week 48, 96, and at other time points as shown there. At week 96, samples with viral load above 400 copies were retrospectively sequenced for genotypic resistance, and drug resistance mutations at week 96 and resistance scores were defined using Stanford algorithm. So looking at the results and first the anchor drug, we can see that we had higher suppression rates for participants on dolutegravir and darunavir compared to atazanavir and lopinavir. When we looked at the sequencing and HIV drug resistance mutations, we saw for major protease mutations, we only got one participant with resistance to atazanavir. And then we only got 2 participants in the dolutegravir arm getting major integrase mutations. It's important to note that these 2 participants were also taking AZT as part of their NRTI backbone. Looking at the NRTI backbone comparisons, we again see we had better suppression with TAF and FTC, and there was significant higher resistance in the to NRTIs in the standard of care arm, which was abacavir and zidovudine. And this was driven mainly by resistance to FTC and 3TC and basically by the M184V mutation. For tenofovir, we also got 3 participants only who developed resistance, and you can see the display on the right-hand side in the graph. The main difference really was between the 2 groups was for FTC and 3TC resistance. So in conclusion, emergent high-level resistance to dolutegravir and protease inhibitors was uncommon, unlike what we saw, I think, yesterday, which was in programmatic setting. We did not see any darunavir resistance, and only 1 case of high-level dolutegravir resistance was seen. Intermediate level tenofovir resistance was observed only in TAF and FTC arm. However, this was rare, and no K65R mutations were detected. Resistance to 3TC FTC was more common in standard of care. Baseline resistance testing is ongoing, and we want to identify factors associated with virologic failure and emergent resistance. But we are also discussing on how we can combine data from the Odyssey trial, which was also presented yesterday. We only have a few mutations in this study, but the combination of AZT and DTG we need to explore more, and also using adult data which we have from NADIA and other studies. This would not have been possible, this study and the sub-study, without the all these groups here, participants, funders, partnerships, and pharma that gave us the drug. Thank you very much for those of you who are here for contributing to this oral poster, and looking forward to seeing you at lunchtime, if you must skip lunch.